Hi, I'm Frances. I'm one of the HEMS doctors at the Hampshire and Isle of Wight Air Ambulance. And today we're going to show you our simulation suite. This is where we train on a daily basis, performing skills and interventions that are required to patients of a critical nature. We're going to demonstrate a simulation of a road traffic accident and the kind of interventions that we can bring to the patient at the roadside. We can bring the ventilator and blood to the patient pre-hospitally, which will improve their outcome in the long term.
So Fran, we've come to this motorcyclist. It looks like he's fallen off his motorbike and his helmet's come off already.
Yeah.
I can't see any massive hemorrhage, can you?
No, it looks safe to approach, so let's go in. I'll get in and assess his airway first of all. So, hello sir, can you hear me? Okay, so he's not really responding there to me. He's not opening his eyes. I'm just inflicting some response. So he's not opening his eyes. He is groaning and is extending. Okay, so we've got about a GCS of 1, 2, 3, so GCS of 6. Okay. He's got a little bit of snoring there, so can I get an oropharyngeal airway? So we're just going to pop this in. This is going to support his airway temporarily while we do a further assessment. Just going to pop this into your mouth, sir. There we go. So he's tolerating that well, and we'll pop some oxygen on, so that we'll fill that bag up and pop that over his mask.
While you're doing that, Fran, I'm just going to put some monitoring on.
Yeah, that would be great, and I'll continue to do his primary survey. There we go,
just going to expose his chest.
All right, I'll pop this out of the way. I'll come around this side. This is bad. Okay, so I've had a look at his airway, so breathing. All right, he's got bilateral chest movements there. I'll have a little feel. There's no obvious deformities or crepitus on his chest.
Nope.
Blood pressure.
So that's just cycling for you. We'll get that up in a moment.
Good, so we've got some saturation, so I'm feeling for a radial pulse there, which will tell me in the meantime that he's got reasonable blood pressure, and he's got a good blood pressure there. All right, I noticed some bruising on the right upper part of his tummy, so that might indicate some internal injuries, in particular to his liver. Feels nice and soft, doesn't appear to be grimacing with pain. And now we've got our blood pressure. So his blood pressure is 103 systolic, which is a little bit low for this gentleman, and his heart rate is fast at 127. Okay. So if you're happy to get some intravenous access. Yeah. All right. Julian, I think we should put a pelvic binder on this patient. The mechanism of him coming from his motorcycle is a high risk for a pelvic injury. Yep. With a pelvic fracture, you can lose the whole volume of your body's blood into the pelvis. So the purpose of the pelvic binder is to try and compress that injury and reduce the blood loss.
Lovely. So I'll come round and let's
put that on now.
Do it.
Okay, so if we just pop this under his legs, I'll speed it through to you.
Lovely, I've got it.
Okay, and then we'll just move that gently up, being careful not to move him too much.
Lovely.
So I'm just feeling for the level of his greater trochanters.
Yep.
Okay, I'm happy with that level now. So if we bring that together, one end for you. So this device is called a T-pod, and then we can pull it together, which pulls any parts of the broken pelvis together. So this brings the two halves of the pelvis together and then reduces any blood loss the patient may have from a pelvic fracture. So it's what we call a rapid sequence induction, and that basically means that we use drugs to quickly put him into an induced coma and paralyse him, and that allows us to put a breathing tube and carefully control his breathing for him. Okay, so I'm going to switch that over to what we call a bag valve mask. All right, so just going to put a mask on your face. So he is breathing for himself, but I can, with his breath, just support his breathing to make sure that we have optimal conditions. The reason for this is we want a person with a head injury not to have low oxygen levels, as that can have consequences in their recovery.
Yep, so laryngoscope, we're going to use a video laryngoscope because this patient looks like they might have a more difficult airway.
Yeah, we need to protect his cervical spine because he's had a trauma, so we don't want to move his neck at all.
Yeah, we've got a bougie, we've got our tube, which is a size 7, and it's cuffed and lubed. We have our filter mount and end-tidal CO2 and our BVM. Rescue ventilation, we will use an iGel, a size 5 for this gentleman. Yeah. We've got our surgical airway pack, should we need it.
Yeah.
Fentanyl dose.
So I estimate this gentleman's 90 milligrams, so we'll go a 1-to-1 regime.
Yeah.
So fentanyl 90, ketamine 90 and rocuronium 90.
Sounds good. Intubating clinician.
This is myself.
Assistant, that will be me. Plan A.
If you can do some mid-inline mobilisation.
Yeah.
And I will use a bougie and the video laryngoscope and the size 7 tube as planned.
Plan B will be an iGel and Plan C will be a front of neck.
Yeah, he's easy to ventilate, so I think the iGel should be adequate.
Excellent. Okay, so I'm happy to push the drugs now.
So the patient should now be anaesthetised and paralysed.
Just timing 60 seconds on my watch, starting now.
You have those, and if you do the inline immobilisation.
Okay, so here's your video, here's your bougie. I'm doing inline immobilisation.
Okay, so that's to prevent me inadvertently moving the neck, which could cause injury to his spine.
Yep.
Okay, so the minute has passed.
Yep.
The patient is paralysed, he's not making any respiratory effort, so I'm happy that we go ahead. Okay, I'm going to remove this. Thank you. Okay, so I'm using the video scope to get the best view first time. So I've got a grade 1 view of the cords. I'm inserting the bougie, and the bougie has passed through the cord. The bougie allows us to get access in between the vocal cords, which you can see on the screen there. And now you're passing the intubation
so I've got
tube.
The bougie.
Okay, I'm placing the tube, and we can watch the tube pass through the cords there. I'm happy that that's between the cords, so you can remove the bougie. Okay, and if you can attach...
I'm just going to put the cuff up.
Yep, and if you then attach the bag valve mask.
So this is
so I'm
now
happy there, that's
attached.
good. And we can ventilate the patient.
Lovely. So as we're ventilating, I can see end-tidal CO2, I can see misting of the tube, I can see chest rise and fall equal on both sides.
Yep.
I'm just going to get my stethoscope out and have a listen. And then once we've confirmed placement, we'll tie the tube off.
Yep.
All right. So if you just do a breath for me there. Yeah, good air entry. Good air entry.
Great.
And no air entry,
Wonderful.
which is good for the esophagus.
Okay, so let's secure that. We can reassess the patient, ensure that they're still stable, and then I think at that point we can move the patient towards transporting the patient to hospital.
Yeah.
So I think from our location, the best option is to fly the patient, because this is a time critical need for the patient to get to hospital and potentially need operating theatre. And in the back of the aircraft we can put him on our ventilator machine, and I think we should take him to the major trauma centre with his injuries, which our closest would be Southampton.
Perfect, sounds good.
Great, thank you.
As you can see in some of these patients with critical injuries, they might not make it to hospital before getting interventions. The idea of our critical care team is to bring the hospital to the patient where they can receive life-saving treatment. Some of these interventions that we do, the ambulance service isn't able to offer, and so we're able to add these things to the pre-hospital care so that patients that we see have a better chance of survival and a better chance of going home and having a good neurological outcome. Lastly, we would like to say thank you to you. It's thanks to your donations that we're able to run this service. It's not inexpensive to have a doctor, a paramedic and a pilot provide this service to patients, and without you we wouldn't be able to do this. You're the reason that we're able to run our service and to see these patients and help them as best we can, so thank you very much.